we talk about left main disease. About 4.8% of the patients undergoing coronary angiogram have left main. Male gender and age are the only independent predictors, and associated with 3-vessel disease in approximately 50% of the patients. Isolated left main in 5%, which is more frequent in women. And bifurcation involvement, 74% versus a shaft or ostium, about 24% of the disease. And flow-limiting stenosis of left main compromises flow to at least 75% of the left ventricular myocardium. And that's most probably the reason why they're present in cardiogenic shock. We'll skip this one. Based on Medina, you can classify bifurcations. And here is the prevalence in different trials that looked at syntax and main and delta. Ostial only is seen in about 22% in the syntax, whereas the distal bifurcation is more common in about 50 to 60% in all these trials. So the distal bifurcation is obviously, maybe overall about 70%. Andreas Grunzig's third PTCA was supposed to be was supposedly a left main disease in September 1977 in a patient with the severe angina pectoris, and first angiogram is revealed severe stenosis of the left main coronary artery. The patient expired suddenly about 4 months after this procedure, even though that's probably the reason he was always recommending not to stent left main. His dream was a catheter-based percutaneous treatment of vascular disease in alert and awake patients with utmost safety, appropriateness, and ambulatory procedures. So you look at these trials, Excel and Noble, 1,900 and 1,200 patients, and we'll probably look at it more in a little bit of a depth. In these two trials, comparing PCI versus bypass surgery, one of them is in UK and Scandinavia in 7 centers, and Excel is in 17 centers involving United States, Europe, Asia, Pacific, and Middle East, and South America, and less than 32 syntax score in Excel, no restriction in Noble, and the primary endpoint was periprocedural MI was included in Excel and not in Noble, which was causing a lot of debate, not even yet now as well. The stents that I used are all new generation, latest generation stents, and the 3-year definite stent thrombosis rates were 0.8% in Excel and 3% in Noble, and the graft occlusion and definite stent thrombosis were also in Excel and not in Noble. So let's look at the 5-year data of Excel, primary endpoint of all-cause death, stroke or MI. Initially, PCI did better than surgery, and at 2 years, there was no difference. 3 years, there's not much of a difference. After that, 5 years, now PCI is worse than bypass surgery. So it is not still statistically significant, but the numbers are increasing. So the mortality is seen about in 13% in the PCI group versus 9.9% in the bypass group, and this is what is more worrisome for most of the physicians. And in the Noble trial, the primary endpoint of a major adverse cardiac and cerebrovascular events, there is a big difference in favoring bypass surgery in the blue as compared to PCI, with an absolute difference of about 6% and a hazard ratio of 1.46, which is statistically significant. The pre-combat is a Korean study looking about 300 patients in each arm, and PCI versus CABG looked at the 10-year data. Now we have the primary endpoint of major adverse cardiac and cerebrovascular events intention to treat analysis showed that still PCI has higher rates of the primary endpoint at 29.8% versus bypass surgery at 24.7%. But this is mostly driven by ischemia-driven target vessel revascularization in pre-combat. There was no difference between death or MI in this study. So mainly about 8% difference in ischemia-driven TVR favoring bypass surgery than PCI. So if you combine all these other syntax, pre-combat, Noble, Excel, and 4 randomized control trial analysis that was presented by Mark Sabatine in 4,394 patients and published in 2021 Lancet, it shows that 5-year all-cause death is an absolute risk of 1% in the PCI arm, which is not statistically significant. 10-year all-cause death, about 2% absolute difference. Higher in the PCI, still not statistically different, but the main thing is run by coronary revascularization, which is about 8% absolute increase in PCI compared to CABG, and also myocardial infarction. So you look at cumulative incidence of key clinical outcomes in all of these trials. The bypass surgery, spontaneous myocardial infarctions are much lower than PCI, and procedural MI as well as protocol definition or universal definition. Definitely there is a slightly increase in universal definition MIs in PCI than as compared to bypass surgery. So this has been a contention by how Excel used a protocol definition, which is slightly higher in CABG as compared to PCI. So the stroke, there's no statistical difference, but repeat revascularization, once again, is higher in PCI, which is not unknown to all of us. But in 5-year all-cause death in subgroups, I think key subgroups, still everything is in favoring mostly with the bypass surgery. Mortality is slightly higher in all the groups, except in left main plus one vessel, which is probably PCI is favored. So I think rather than saying, why should I not do PCI in everybody, why should we do PCI? So the PCI probably is not preferred if there is inability to take DAPT. There's diffuse disease and unprotected major branches, absent access, inability to completely revascularize, and the patient's preference. If they want to go for surgery, we should respect that. And a chronic kidney disease, probably that is still a debate. And this is talking about DAPT in ideal left main. They looked at short DAPT versus long-term DAPT using synergy for 4-month DAPT versus Zions and 12-month DAPT in left main patients, with all-comers syntax score more than 32, ACS, and all ejection fractions. So this was in 29 sites initiated research in the UK and Europe, and 5 countries, December 2014 to 2016, and primary endpoint was 2-year MACE of death, MI, ischemia-driven TVR. That said, there is a slight increase in Kaplan-Meier MACE, higher in the Zions arm than in the synergy arm, but it was not statistically significant. So let's come to DK crush. So then once we divide that we are going to do PCI, DK crush compared DK to 3 study compared outcomes of DK crush and Coulott stenting in distal left main, favoring DK crush. So in view of time, I'll go slightly faster. DK crush 5 trial for left main stenting, provisional versus DK crush, was evaluated in this trial, and it showed that actually provisional stenting had the higher cardiac death, MI, and TLR, but the only statistically significant one was target vessel MI and stent thrombosis rates. So definition 2 was actually designed after the DK5 started, and Dr. Chen and his group divided patients into major criteria, minor criteria based on the lesion significance in a left main, where if there is a more than 70% branch disease and if the length of the lesion is 10 millimeters, and they're considered as a complex lesion, and versus a simple lesion is obviously less than that. We are talking only about left main, so I'll skip this. Side branch stenosis of more than 90 is in non-left main disease. So applying this type of division of lesions into simple and complex lesions getting 2 stents versus provisional group, which is the simple lesions, and they were followed for about 3 years, and it showed that actually TLR, TVMI, and target lesion failures were definitely much higher in provisional stent if that is applied to a complex bifurcation lesion. So the same landmark analysis was done for 3-year results, which showed that in complex lesions, provisional stent strategies have higher major adverse cardiac events. So that was looked in DK crush 5, and DK crush 5 actually saying that simple lesions, they don't do well with the provisional versus complex lesions do worse, much worse with provisional stent strategy than DK crush. So then EBC main looked at actually systematic provisional and systematic dual stenting, but the Coulott is the preferred stenting in EBC main, and they showed that the stepwise provisional is not a drawback, so that we can use stepwise provisional rather than a dedicated 2-stent technique. Whatever said and done, here is how we divide the patients in Excel. 1 provisional versus planned 2 stents. Planned 2 stents had higher event rates in Excel as well. But using IVUS is very important at 3-year outcomes, and I think achieving an IVUS minimal stent area of more than 12, which is a higher tertile, had shown to have lower death, MI, and stroke rates. So DK Crush 8, which is a dedicated left main IVUS guided stenting, is awaited. So I'll tell you that in my in real life, the spectrum of patients differ from what we see in randomized clinical trials. Patients present with advanced disease and more complex anatomy, and PCI of left main is technically feasible with high success rate even in complex anatomy, and a patient-centric approach needs to be followed after a hard team discussion. Thank you.